Hello, everyone. Locals, forum supporters, welcome. This is the October webinar, and it's a fun one. Popliteus, the key to unlocking the knee. First, a little bit about anatomy. So the path of the popliteus, the belly of the popliteus starts on the medial side of the tibia, and the tendon thins out and attaches to the lateral epicondyle of the femur. And there it also has an attachment to the lateral meniscus. This here on the right, remember, it's encased in the capsule itself. That's the tendon of the popliteus. And what runs over that is the tibial nerve. So we can see how deep the popliteus is. This is a popliteus motor point from the manual. If you don't have it, you should get it. The Acupuncture Motor Point Manual for TCM practitioners. And the innervation is L4, L5, S1. The action, it flexes and immediately rotates the leg at the knee. Now, we're going to talk more about this right now. The popliteus assists in knee flexion. Its function is dependent on whether the lower extremity is weight-bearing or not weight-bearing. So it's considered to be an internal rotator of the tibia when it's in a non-weight-bearing state. And it makes sense because it's attached to the tibia itself. So when it pulls, it internally rotates. When the knee is in complete extension and we're in weight-bearing, the popliteus contracts and causes lateral rotation of the femur. So that tendinous attachment at the femur, this part right here, pulls in this direction. See where this arrow is? Causing the knee to unlock. So when it's weight-bearing, it externally rotates the femur. When you're not weight-bearing, it internally rotates the tibia. So remember to think that over, watch this again, make sure you have that because it's very important. When the knee motions in flexion, the popliteus retracts the lateral meniscus posteriorly, avoiding an entrapment between the femur and the tibia. That's why it has that attachment right here where the blue is. And when it externally rotates the femur, it pulls back the lateral meniscus and it prevents any compression of that meniscus. So key concepts to remember. One's motor inhibition. Muscles get shut off for three reasons: pain, trauma, and changes in the joint. Now, in this popliteus, this happens for many different reasons. You can have osteoarthritic change. You can have post-surgery. You can have total knee replacement. So we're going to talk about some of these. And of course, all of the three things I mentioned are forms of noxious stimuli. The nociceptors and mechanoreceptors in the muscles and the joint provide noxious stimuli back through the spinal cord. And remember, garbage in equals garbage out. Nociception in equals decreased motor function out. Reciprocal inhibition is the key when speaking about popliteus, because first, reciprocal inhibition. We have pairs of muscles that move in instant opposite direction. The agonist moves the muscle and the antagonist do not oppose movement. So let's talk about the popliteus. When it contracts, its antagonistic pair is the quadricep, all four quadricep muscles, because it extends. When the quadricep contracts, the popliteus has to extend. But if the popliteus can't contract because it's inhibited, the opposite muscle, which is the quadricep, forms knots. It bunches up, and vice versa. You have an inhibition of the quadricep after a total knee replacement. They cut right through the knee, right through the quadricep. So you're going to get contraction of the popliteus, which means you're going to get decreased knee flexion. And that's what happens after a total knee replacement. The goal is 120 degrees of knee flexion, and often it's not achieved because they don't address the popliteus. This is the example right here. They cut right through here, which causes an inhibition of the quadricep, and of course, that causes a contraction of the popliteus. So clinical significance, we get this in osteoarthritis, affects proprioception, affects the role of the cutaneous nerve. Restoration of cartilage, there's a technique we can do to help restore this. But of course, when this happens, you get inhibition of quadriceps. You're also going to get inhibition of the popliteus because of its lateral attachment. So addressing the popliteus in osteoarthritis is a good thing. Post-traumatic osteoarthritis is something that happens in younger people. It can happen in older people, but any type of trauma at any age can help facilitate the decrease of synovial fluid, because the fragments of the chondrocytes that are degraded or injured during trauma, they suck up the synovial fluid, which decreases the lubrication. And if you decrease lubrication, you increase bone on bone, you increase friction, which you increase osteoarthritis. Post-surgery. All right. So often I have patients coming in, let's say a year after a knee replacement, and they never got proper or optimal recovery of flexion and extension. And so what we do, we have to work on the quadricep. We have to work on the scar. We have to work on the popliteus. We have to needle these areas in order to get proper function. So let's talk about the research. Manipulation of the popliteus. So post-surgery, doing some soft tissue work, or post-treatment, doing soft tissue work, says the effect of soft tissue manipulation of the popliteus muscle on the quadricep. And so if you look at this study, it said if you treat the popliteus muscle manually, you can improve the activity or function of the quadricep muscle. It's reciprocal inhibition, just what we talked about. Motor point stimulation. What's important about this is making sure you get deep enough and that you follow the directions. Popliteal fossa, distal 2.5 inches, and you needle. It is a deep needling, approximately 2 centimeters. I like to go a little bit deeper. Sometimes you're going to stimulate the tibial nerve. That's okay. You're still getting a contraction of the area. Assessment of non-traumatic knee pain. We have to use EXSTORE, because clinical trends will tell us that any type of knee pain has with it inhibition of the TFL, inhibition of the gluteus medius, and with all functional knee pain cases, the lower body EXSTORE must be part of your exam. This is also true with osteoarthritis patients and non-acute knee pain patients without chronic systemic conditions. And EXSTORE is in line with the research. If you look at, this is from the North American Journal of Sports and Physical Therapy. They were assessing hip strength and knee pain in females, and they determined that strength of the gluteus medius and maximus muscles were significantly less in the extremities of patients experiencing knee pain versus those without knee pain. The conclusion was the results of the study provided data that suggested that individuals with knee pain had weak hip muscles. And that's exactly what EXSTORE talks about. So how do we assess osteoarthritis? Well, really, it's a visual inspection. You can also feel the knee is very boggy, almost a deformity exists. Supine knee extension is limited. Supine knee extension, which should be 180 degrees or 0, depending on how you're using the goniometer, it is not. It's not fully at 0 degrees. And then gait observation. You can see a lot in the gait observation. So the treatment protocol. What do we do? Well, we do popliteus motor point stimulation with the pointer plus. Very important to do that. And that's because we need to neuromodulate the mechanoreceptors and the proprioceptors. Make sure to locate the center of the popliteal fossa and move distal 2.5 inches. Insert the needle oblique to the tissues from cephalad to caudal, so down in this direction, oblique. And oblique, because that way you don't have to needle as deeply. You can feather through all of the tissues. Stimulate the point with the pointer plus, making sure your non-dominant hand is close to the needle and gently depressing the tissue. If you do it at an oblique direction, it's less noxious than if you do it totally P to A for the popliteus. Otherwise, it'll create some nociception when you press down. So this I want to set up for you. It's a really nice video, and it shows stimulation at the same time of the popliteus and the vastus medialis. So there are two muscles that are antagonistic pairs. And we are actually addressing the popliteus anterior to posterior, obliquely, medial to lateral. So it's through the acupuncture, traditional acupuncture point, spleen 9. And we're getting it there. And then what you see so succinctly is because the foot is not at in a weight-bearing position, it's non-weight bearing, you see clear internal rotation of the knee itself and at the tibia. So keep that in mind. The popliteus is a small muscle. There's really not a lot to say about it, but the things we do have to say about it are very important. Remember, osteoarthritis, post-surgery or post-surgery, you need to address the popliteus because it'll help maximize knee extension and help maximize knee flexion. It'll improve your metrics, especially if you're doing rehabilitation. Remember, log on to Locals. I'm here twice a month. Bring your patients, get active. This is school away from school. We'll talk soon. Enjoy the video.
Okay, this is we're demonstrating the difference between tibialis posterior motor point, which is 4 inches above the medial malleolus, and the motor point for the popliteus. And this is a 75 millimeter needle that's been buried going medial to lateral. I have a needle hooked up here. This is an arbitrary point just in the bone of the tibia. Now, the EDO is on. This is what the tibialis posterior motor point looks like. We get some inversion of the foot. See that? And contraction there. So this should not be confused with the popliteus motor point, which is also supplied by the tibial nerve, which what happens, it actually medially rotates the tibia. It medially rotates the femur on the tibia when the knee is extended. So we see that dramatic difference versus and one more time. You can see the eyes of the knee where the femur is actually moving. So this is a demonstration, so you know the difference, so you don't think you're getting one over the other. But they can be confused if their needle placement is off.